Hello everyone, and welcome back to another chapter of Advanced Pharmacology. Today we're talking about Unit 14, Drugs for Bone and Joint Disease, and we'll speak specifically on Chapter 58, Drug Therapy of Gout. Gout is a painful inflammatory disorder seen mainly in men. Symptoms result from the deposition of uric acid crystals in the joints. We begin by discussing the pathophysiology of gout, after which we will discuss the drug used for its treatment. So, the pathophysiology. Gout is a recurrent inflammatory disorder characterized by the hyperuricemia, or high blood levels of uric acid, and episodes of severe joint pain, typically in the large toes. Hyperuricemia, defined as blood uric acids above 7 milligrams per deciliter in men or 7 milligrams per deciliter in women, can occur through two major mechanisms. The first being the excessive production of uric acid, and the second the impaired renal excretion of uric acid. Acute attacks are precipitated by the crystallization of sodium urate in the synovial space. Deposition of urate crystals promotes inflammation by triggering a complex series of events. A key feature of the inflammatory process is infiltration of leukocytes, which, when inside the synovial cavity, phagocytize urate crystals and then break down, causing release of destructive lysosomal enzymes. When hyperuricemia is chronic, large and gritty deposits known as tophi may form in the affected joint. Also, deposition of urate crystals in the kidneys may cause renal damage. Fortunately, when gout is detected and treated early, the disease can be arrested and these chronic sequelae avoided entirely. So, our overview of our drug therapy. In patients with gout, drugs are used in two ways. First, they are given in short term to relieve symptoms of an acute gouty attack. Second, they are given long term to lower blood levels of uric acid. In a patient with infrequent flare ups, so less than 3 per year, treatment of symptoms may be all that is needed. Nonsteroidal anti-inflammatory drugs, or NSAIDs, are considered first-line agents for relieving pain of an acute gouty attack. Glucocorticoids are an acceptable option. In the past, colchicine was considered a drug of choice for acute gout, even though it has a poor risk to benefit ratio. Today, colchicine is generally reserved for patients who are unresponsive to or intolerant of safer agents. So, in patients with chronic gout, tophaceous gout, or frequent gouty attacks, drugs for hyperuricemia would be indicated. Three types of drugs may be employed: agents that decrease uric acid production, agents that increase uric acid excretion, and finally, agents that convert uric acid to allantoin. A discussion of drugs used to treat gout will follow. Drug preparations, dosage, and administration will be presented in Table 58.1, as well as a lifespan consideration, which will be provided in Box 58.1. So, if we're talking about drugs for acute gouty arthritis, again, the nonsteroidal anti-inflammatory drugs do, however, come with a black box warning. NSAIDs may increase the risk for myocardial infarctions, strokes, and thromboembolic events. NSAIDs increase the risk for dangerous gastrointestinal adverse effects, which do include bleeding, ulceration, and perforation. So, for an acute gouty arthritis, NSAIDs are considered agents of first choice. When compared with colchicine, NSAIDs are better tolerated and their effects are more predictable. Benefits derive from suppressing inflammation. Treatment should start as soon as possible after symptoms onset. Most patients experience a marked relief within 24 hours. Swelling subsides over the next few days. Adverse effects of NSAIDs include gastrointestinal ulceration, impaired renal function, fluid retention, and increased risk for cardiovascular events. However, because of the duration of treatment, which is brief, the risk for these complications are considered low. So then the question comes, which NSAID should we use? Well, there's no good evidence that any one NSAID is superior to others for the treatment of gout. Commonly used NSAIDs include indocin, naproxen, and there are a couple others. So this brings us to table 58.1. Again, the different preparations, dosages, and administration of anti-gout medications. So here is an excellent spot to hit pause and review different kinds of gout medications. So we'll touch up now a little bit on glucocorticoids. Glucocorticoids, also known as prednisone, given orally or intramuscularly, are highly effective for relieving an acute gouty attack, although NSAIDs are generally preferred. Candidates for glucocorticoid therapy are those patients who are hypersensitive to NSAIDs, patients who may have medical conditions that are contraindicated for the use of NSAIDs, and patients who have severe gout that are unresponsive to NSAIDs. Because of their effects on carbohydrate metabolism, glucocorticoids should be avoided, and when possible, in patients prone to hyperglycemia, so your diabetic patients. For oral therapy, prednisone may be used. For intramuscular therapy, triamcinolone acetonide may also be used. Glucocorticoids are discussed in further detail in chapter 56. Which brings us to the next medicine, colchicine. Colchicine, also known as Colcress or Midigar, is an anti-inflammatory agent with effects specific for gout. In the past, colchicine was considered a first-line drug for gout. However, owing to the common occurrence of GI toxicity and the availability of safe and effective alternatives, its use has begun to decline. However, it does have a therapeutic use. Colchicine has two applications in gout. First, it can be used short-term to treat an acute gouty attack, and second, it may be used long-term to prevent attacks from reoccurring. Colcress is approved for both uses, whereas Midigar is approved only for prophylactic use, so not for the acute gouty attack. Acute gouty arthritis. High-dose colchicine can produce dramatic relief of an acute gouty attack. Within hours, patients whose pain had made movement impossible are able to walk. Inflammation disappears completely within 2 to 3 days. For the prophylaxis of gouty attacks, when taken during asymptomatic periods, low doses of colchicine can decrease the frequency and intensity of acute flare-ups. Colchicine may also be given prophylaxis when urate-lowering therapy is initiated, because there is a tendency for gouty episodes to increase during that time period. So how does colchicine truly work? Well, we don't fully understand how colchicine still relieves or prevents episodes of gout. We do know that colchicine does not decrease urate production or promote its removal. It may work, at least in part, by inhibiting the leukocyte infiltration. In the absence of leukocytes, there is no phagocytosis of uric acid and no subsequent release of lysosomal enzymes. How does colchicine inhibit leukocyte migration, therefore? Well, it does disrupt microtubules. The structure requires for cellular motility, because microtubules are also required for cell division. Colchicine is toxic to any tissue that has large percentages of proliferating cells. The disruption of cell division in the GI tract and bone marrow underlies major toxicities of the drug. So, its pharmacokinetics. Colchicine is readily absorbed after oral dosing in both the presence and absence of food. Large amounts re-enter the intestine through the bile and intestinal secretions and then undergo reabsorption. Final elimination occurs primarily through two processes: metabolism by the hepatic CYP3A4 and the isozyme or of cytochrome P450, and finally the renal excretion of intact drug. So, what are some adverse effects for the patients that are carried across the lifespan? Drugs for gout. Here is that spot for you to hit pause. So this way you can read the different stages for children, pregnant women, breastfeeding, and the older adult. Some gastrointestinal effects. The most characteristic side effects are nausea, vomiting, diarrhea, and abdominal pain. These responses, which occur during treatment of acute gouty attacks, result from injury to the rapidly proliferating cells of the GI epithelium. With the high doses used in the past, these GI effects developed in nearly all patients. However, with the lower doses being used today, GI toxicity has become less of a common problem, but may still develop in about 25% of patients. If GI symptoms do occur, colchicine should be discontinued immediately, regardless of the status of the joint pain. Myelosuppression. Injury to rapidly proliferating cells can suppress bone marrow function and can thereby cause leukopenia, granulocytopenia, thrombocytopenia, and pancytopenia. Accordingly, colchicine should be used with caution in patients who have a history of hematologic disorders. Myopathy. Colchicine can cause rhabdomyolysis during long-term low-dose therapy. Risk is especially increased in patients who have renal and hepatic impairment, and in those patients who may be taking statins, which can cause rhabdomyolysis on their own. Patients should be monitored for signs of muscle injury. So, different drug interactions. Speaking on statins, as noted, atorvastatin, simvastatin, and other statins can increase the risk for colchicine-induced muscle injury. When possible, combination use of statins and colchicine ought to be avoided. There are drugs, though, that can also increase colchicine levels. Life-threatening reactions have occurred when combining colchicine with two classes of drugs, the P-Glycoprotein inhibitors and inhibitors of any kind of CYP3A4. Again, recall from Chapter 4 that PGP is a transporter protein that can reduce plasma drug levels through effects in the liver, kidney, and intestines. Therefore, by inhibiting PGP drugs such as cyclosporin and ranolazine, which can cause colchicine to accumulate to a toxic level. Similarly, by inhibiting CYP3A4 drugs, such as ketoconazole, clarithromycin, and the HIB protease inhibitors, can cause colchicine levels to rise. Accordingly, combined use of colchicine with strong inhibitors of either PGP or CYP3A4 should generally be avoided and is contraindicated in a patient who has hepatic or renal impairment. So, are precautions and contraindications, therefore? Colchicine should be used with care in the older adult population and with debilitated patients, and in patients who may have cardiac, renal, hepatic, or GI diseases. As noted, combined use of colchicine with a strong inhibitor of PGP or CYP3A4 should generally be avoided. For both acute therapy as well as long-term prophylaxis, dosage should be adjusted on the basis of liver function, kidney function, and the use of interacting drugs. Prescribing information for Mitigar, but not Colchris, includes contraindications for hepatic or renal impairment. Colchicine is classified by the FDA at pregnancy risk category C, so it should be avoided during pregnancy, unless it is perceived that its benefits outweigh the potential risks to the infant. Which bring us now for drugs for hyperuricemia, or urate-lowering therapy, also known as ULT. Urate-lowering therapy is indicated for a patient who experiences relatively frequent acute gouty attacks. The goal is to promote the dissolution of urate crystals, prevent new crystal formation, and prevent disease progression, reduce the frequency of acute attacks, and improve the quality of life. For most patients, ULT must continue lifelong. There are 4 drugs that will help you do that: allopurinol, febuxostat, probenecid, and pegloticase, all of which are used to reduce uric acid levels. 3 mechanisms are involved. Allopurinol and febuxostat inhibit the uric acid formation, which is why they're most commonly used. Probenecid accelerates uric acid excretion, and pegloticase converts uric acid to allantoin, a compound that is readily excreted by the kidney. With all four drugs, the goal is to reduce plasma uric acid to 6 mg per deciliter or less. These drugs lack anti-inflammatory and analgesic actions, so they are not useful against any kind of acute gouty attack. The effects of all four drugs on the uric acid are shown in the following figure. So here's an excellent spot to hit pause so you can kind of take a look at the pathophysiology behind it. That brings us to xanthine oxidase inhibitors. So that would be our allopurinol and febuxostat. So two xanthine oxidase inhibitors are now available, allopurinol and febuxostat. Both seem equally effective. Allopurinol has been used for decades, whereas febuxostat is considered relatively new. Because experience with allopurinol is more extensive and febuxostat is much more expensive, allopurinol is most often preferred. So, speaking on allopurinol, its therapeutic use. Allopurinol, also known as Xyloprim, is the current drug of choice for chronic tophaceous gout. By reducing blood uric acid levels, allopurinol prevents new tophus formation and causes regression of tophi that have already formed, thereby allowing joint function to improve. Reversal of hyperuricemia also decreases the risk for nephropathy from deposition of uric crystals in the kidneys. Allopurinol can be used for hyperuricemia that develops secondary due to cancer, chemotherapy, and to certain blood dyscrasias, such as polycythemia vera, myeloid metaplasia, and leukemia. Hyperuricemia develops during chemotherapy because when the cells die, the breakdown of DNA releases uric acid. To try and minimize hyperuricemia, allopurinol should be administered before chemotherapy starts. So how does it work? Its mechanism of action is allopurinol and its major metabolite, alloxanthine, inhibit xanthine oxidase, an enzyme required for uric acid formation. Xanthine oxidase catalyzes the final two reactions that lead to the formation of uric acid from the breakdown products in DNA. So, its pharmacokinetics. Allopurinol is well absorbed after oral dosing and then undergoes rapid conversion to alloxanthine, an active metabolite. Alloxanthine is then eliminated slowly by renal excretion. Because alloxanthine has a prolonged half-life, which is about 25 hours, therapeutic effects are long-lasting. Consequently, once-a-day dosing is adequate. So, what kind of adverse effects do we have then with allopurinol? Well, it's generally well tolerated. The most serious toxicity is rare, but potentially fatal hypersensitivity syndromes, which are characterized by rash, fever, eosinophilia, and the dysfunction of the liver and kidneys. If a rash or fever develops, allopurinol should be discontinued immediately. Many patients recover spontaneously. Others may require hemodialysis or glucocorticoid therapy. Initial therapy may elicit an acute gouty attack. This can be prevented by giving colchicine or a low-dose NSAID. Mild side effects are seen occasionally, which also include GI reactions, nausea, vomiting, diarrhea, and abdominal discomfort, as well as neurologic effects, drowsiness, headaches, and a metallic taste. With prolonged use, so use for more than 3 years, may cause cataracts. Periodic ophthalmic examinations are therefore recommended. The risk for drug accumulation can be a problem if administered to patients who do have a history of renal impairment. This can be minimized, however, by decreasing the dosage. Other drug interactions. Allopurinol can inhibit hepatic drug metabolizing enzymes, therefore delaying the inactivation of other drugs. This interaction is of particular concern for patients who are taking Coumadin, whose dosage should not be reduced. When possible, combined use with mercaptopurine or azathioprine should be avoided because both of these anti-cancer drugs are substrates for xanthine oxidase and therefore could accumulate to a toxic level in the presence of allopurinol. If combined use can't be avoided, then dosage of mercaptopurine and azathioprine should be greatly reduced by almost as much as 75%. Theophylline, a drug for asthma, is also a substrate for xanthine oxidase and therefore should not be combined with allopurinol. The combination of allopurinol plus ampicillin is associated with a high incidence of rash. Again, if that rash develops, allopurinol should be discontinued immediately. So here is another good spot to hit pause so you can see the different kinds of prototype drugs for gout. The big ones again, allopurinol, which we just talked about, probenecid, and pegloticase. We will, however, talk first about febuxostat, or Uloric, which is an alternative to allopurinol. But like allopurinol, febuxostat lowers urate levels by inhibiting xanthine oxidase. Symptoms for gout may flare up during initial therapy, similar as if you're taking allopurinol. Accordingly, patients should receive prophylactic NSAIDs or colchicine for up to 6 months after starting treatment. Adverse effects for febuxostat, which are uncommon, however, include liver function abnormalities, nausea, arthralgia, and a rash. High doses, as much as 80 milligrams per day, are associated with a small increase in cardiovascular events. Similarly to allopurinol, febuxostat should not be combined with drugs that are substrates for xanthine oxidase. Again, theophylline, mercaptopurine, and azathioprine. In contrast to allopurinol, however, which is eliminated entirely by the kidneys, febuxostat is eliminated by hepatic metabolism, followed by renal excretion. So no dosage adjustment is needed for a patient with mild or moderate renal or hepatic impairments. So that brings us to probenecid, a uricosuric agent. So its actions and use. Probenecid acts on the renal tubules to inhibit the reabsorption of uric acid. So as a result, excretion of uric acid is increased and hyperuricemia is reduced. By lowering the plasma urate level, probenecid prevents the formation of new tophi and facilitates regression of existing tophi. Probenecid should not be initiated at the beginning of an acute gouty attack. The drug may exacerbate acute episodes of gout, and therefore treatment should be delayed until the acute attack has already been controlled. During the initial months of therapy, probenecid may induce acute attacks of gout. If an attack does occur, the probenecid should be continued. Colchicine or indomethacin can be added for relief. In addition to its use in gout, probenecid may be employed to prolong the effects of penicillin and cephalosporins. So, adverse effects. Probenecid is well tolerated, again by most patients. However, mild GI effects, nausea, vomiting, anorexia, occur occasionally. These can be reduced by taking the drug with food. Hypersensitivity reactions, which usually manifest as a rash, develop in about 4% of patients. Renal injury may occur from the deposition of urate in the kidney. The risk for kidney damage can be minimized by alkalinizing the urine and consuming between 2.5 to 3 liters of fluid daily for the first few days of treatment. Other drug interactions, aspirin and other salicylates, interfere with the uricosuric action of probenecid. Accordingly, probenecid should not be used concurrently with these drugs. Probenecid inhibits the renal excretion of several drugs, which also including indomethacin and sulfonamides. Dosages of those agents may require a reduction. Leaving us to pegloticase, a recombinant form of uric acid oxidase. So, Pegloticase, or Cryostexa, is indicated for IV therapy of chronic gout in patients who have not responded to oral ULT. Although pegloticase is quite effective, the drug costs between 6.5 grand and higher for a single 8 milligram dose and carries a significant risk for severe adverse effects. Accordingly, pegloticase is considered a treatment of last resort. So how does it work? The drug is a recombinant form of uricase or urate oxidase, an enzyme that catalyzes the conversion of uric acid to allantoin, an inert, water-soluble compound that is readily excreted by the kidneys. Uricase is present in nearly all mammals, but not in humans and higher primates. So, its adverse effects. As with other drugs for ULT, patients are likely to experience a gout flare during the first few months of treatment. To reduce that flare intensity, patients should take colchicine or NSAIDs during that time. During the pre-marketing trials, pegloticase triggered anaphylaxis in 6.5% of patients. Symptoms included wheezing, perioral or lingual edema, hemodynamic instability, and rash. To reduce the risk, patients should be pretreated with an antihistamine and glucocorticoid. Administration should be done in a setting equipped to manage a severe reaction. During pre-marketing trials, infusion reactions were seen in 26 to 41% of patients. Symptoms included urticaria, dyspnea, chest discomfort, erythema, and pruritus. These reactions were seen despite pretreatment with an antihistamine, acetaminophen, and IV glucocorticoid. If a reaction develops, slowing the infusion rate may reduce symptom intensity. Pegloticase is contraindicated for patients with inherited glucose 6-phosphate dehydrogenase deficiencies, so the G6PD deficiency, owing to the risk for hemolysis and methemoglobinemia. Patients at high risk, those of African or Mediterranean ancestry, should be screened first for the G6PD deficiency before getting the drug. So it does have a big black box warning. Pegloticase, anaphylaxis and infusion reactions may occur, as stated below. These typically occur within 2 hours after infusion but may be delayed. Administration should take place in healthcare facilities prepared for managing of life-threatening reactions. They recommend pre-medicating with an antihistamine and a glucocorticoid, and be monitored closely during the infusion. So that brings us to our conclusion: pharmacologic management of gout. As we have mentioned, treatment of an acute gout attack or flare varies from prophylactic management to prevent joint and tissue damage and to prevent recurrent gout attacks. In 2012, the American College for Rheumatology released guidelines for both situations. These are summarized in the ACR algorithm. And here will be an excellent spot to hit pause one last time so you can take a look at their websites. I thank you all, as always, for listening to my readings. This concludes our chapter here today, and I'll see you all at the next one. Till then, take care and goodbye.